Today we'll be going over Module 2. This module discusses long-term care residents. This module will take about an hour and 20 minutes to complete. Before we get started today, I just wanted to briefly list what we'll be covering. Module 2 is all about who long-term care residents are, the aging process, common health experiences of these individuals. And we'll also talk about dementia, including Alzheimer's disease, and then we will wrap up by talking about myths and stereotypes of aging. We will start this module by assessing our personal attitudes about aging and long-term care residents. Then we'll talk about the aging process and common misconceptions about it. Then we'll go over conditions you might encounter, as well as myths and stereotypes about long-term care residents. For Section 1, we'll go over an overview of long-term care residents. Let's begin this module with a discussion about who long-term care residents are. Although we advocate for all residents of long-term service and supports, wherever they live, most of your work will be with residents of long-term care facilities. When you think of someone living in long-term care, what has your experience been? Who do you imagine? Who comes to mind, and what are their characteristics? What makes them unique? When some people think about long-term care residents, they imagine older individuals with a variety of ailments who are dependent on others. Sometimes lost is the realization that residents vary in the same respect as individuals who live in the community. Residents have a variety of backgrounds, life experiences, and roles, such as a mother, a father, a friend, sibling, son, daughter, teacher, nurse, doctor, engineer, coach, farmer, social worker. The list goes on and on. Some residents had a hard life. Some were abused as a child or an adult. Some residents are veterans. Some have seen combat. Some are Holocaust survivors, and some marched for civil rights and made great contributions to their communities. Each one of us can be found in the face of a resident. In reality, residents are not much different from those living in the community at large. Residents have desires, abilities, and the need to have a sense of purpose. Residents are from all walks of life, are young and old, with or without disabilities, just as other populations. It is damaging to stereotype people who live in long-term care. Let's talk about some characteristics of Ohio long-term care residents from the recent data from Scripps Gerontology Center at Miami University of Ohio. Scripps receives state funding each year to study the older adult population receiving long-term services and supports in facilities as well as home care. We'll focus here on people living in nursing homes and residential care facilities. Keep in mind that this is statewide data and that individual facilities may have a different makeup of residents and staff that is likely to reflect the community where the home is. Let's start by looking at some characteristics of nursing home residents. The average age of nursing home residents is about 77 years old. This continues to decrease. For comparison, in 1996, the average age was around 81. Nursing home residents are mostly female. This makes sense because women tend to live longer than men. More residents who are widowed, divorced, or separated, at about 58%. This could be a reflection of not having a spouse to provide care when needed. 85% of nursing home residents are Caucasian. Ohioans living in a nursing home require assistance with between 4 and 5 activities of daily living. These include things like bathing, dressing, and grooming. About 40% have moderate to severe cognitive impairment. This data comes from assessments that nursing homes are required to complete and information provided by facilities to researchers. It is important to note, however, that how cognitive difficulties show up varies by person, and as an advocate, you will always follow the wishes of the residents if they're able to tell you what they want. We don't defer to others until we have tried to converse with the resident first. It's a misconception that everyone ends up in a nursing home if they live long enough. In fact, only about 3% of Ohioans age 65 or older live in a nursing home. That percentage increases with age. So for those who are 85 and older, about 10.5% live in a nursing home. What was once thought of as a place many lived in toward the end of life is now a short-term care provided after hospitalization for most admissions. While there are many individuals who continue to live in nursing homes for long periods of time, this has changed significantly over the past 2 decades. Now let's look at residential care facility residents. These are the facilities that some people refer to as assisted livings. In Ohio, they are licensed as residential care facilities. They have an average age of about 85 years old, which is higher than nursing home residents. Residential care facility residents are mostly female, and 90% of residential care facility residents are separated, divorced, or widowed. Roughly 95% of residential care facility residents are Caucasian. More than 4 in 10 residential care facility residents require assistance with 2 or more activities of daily living. Medication management and bathing were the 2 activity of daily living needs most frequently cited. Reflecting different changes in the industry, 27% had a cognitive impairment, which was an increase from 12% 10 years earlier. The average length of stay for a residential care facility resident is just under 800 days. Residential care facility residents generally require less skilled nursing care than nursing home residents do. While residential care facilities may provide other skilled nursing care on a part-time, intermittent basis, they are not allowed to do so for more than a total of 120 days in a 12-month period. There are some exceptions here. It's important for you to know that because sometimes people live in residential care facilities when they really require more care. Residential care facility vary greatly in terms of level of care they offer to residents. We'll talk about that more in Module 3, but ultimately they must be able to meet the needs of the residents who live there. Moving on to Section 2, this is where we'll talk a little bit about the aging process. Let's start with a conversation about ageism. Although aging is an ongoing process from birth to death, the value of aging is seen differently at different points in life. We get excited about some of the changes, such as a baby's first tooth, and less so for other changes, like seeing the first gray hair. Youth is valued in American culture, while signs of aging are masked with facelifts, wrinkle creams, and hair dyes. The process of physical maturing that is so eagerly anticipated in its first stages of life is viewed differently when the youthfulness begins to change. As an ombudsman, you will likely see ageism in action during your service, and it's important to know that ageism can have real impacts on care. As advocates, we have a duty to combat ageism at every turn. Sometimes in old age, the balance may seem to tip more negatives than positives, but this is not due to the natural aging process. There are many positive aspects of aging. After years of living, individuals tend to have a clear sense of their values and priorities. Older adults can make definite choices about how to use their time and energy. As we age, our priorities may be different from what caregivers, family, or friends may want them to be. We learn ways to adapt to changes and have managed to survive. Because of retirement, many older individuals have greater freedom to pursue interests, like volunteering, to use time to think and to reflect. To paraphrase expert Carl Jung, as we age, we become more ourselves. So, aging isn't the problem. Ageism is. Ageism is the stereotyping, prejudice, and discrimination against people on the basis of their age. Ageism isn't only psychologically harmful, but it can also jeopardize a person's ability to do things, like engage in communities and gain employment. Ageism has even been linked with access to health care. In fact, Not providing high-quality care in a nursing home is an indication that there is insufficient value for life at old age for people living with disabilities. Ageism goes both ways. Anytime you hear someone making a judgment and attributing it to a person's age, whether young or old, it's likely ageism. As ombudsmen, we need to be especially conscious of our values and biases so they don't negatively impact our advocacy. Let's take a minute and think about a few things. What attitudes do we as a society project about age? Think about young people first. How about getting older? How can these impact people? How do your views or the views of others impact interactions? We'll talk briefly now about some of the physical aspects of aging that might impact some of the interactions and problems that you see in your advocacy. All of these have potential impacts on those we serve in different ways. We may all think we know a lot about these, especially if we have lived experience, but we'll talk about some of the potential impacts of these aspects of aging on long-term care residents as we discuss them. Although most of the residents you will see are older, some conditions and illnesses have similar effects. Let's explore some of the structural changes first. The loss of muscle mass and tone can be a normal part of aging. While exercise helps to maintain strength and tone, it does not prevent some loss. However, it is important to recognize the difference between someone with normal loss of tone and neglect. Physical exercise activities should be offered by the provider to maintain physical health. Weight loss is not a normal part of aging, and the cause of it should be investigated. You can ask residents you work with, are staff offering you physical therapy? Are you being assisted in other physical activities to build your strength? Another change affecting appearance is the flattening of the spongy cushion between the vertebrae. Over the years, this material loses its resiliency. Older people may be shorter than they were in younger years and have a stooped posture. What is not normal aging is the loss of bone density. Osteoporosis is a common physical condition among aging women where the bones in the hips, wrist, or spine lose their strength and density and are much more prone to fracture. Someone with osteoporosis could cause a fracture from a particularly strong cough. Skin also changes as we age. Skin may become dry or scratchy. Staff should be attentive to this and make sure residents have lotions and offer to help apply them when desired. Staff should also be very careful when providing care, as skin becomes thinner and can be broken or cut more easily. Pay special attention for unmet needs related to skin, such as dryness and cracking, bruises and cuts. Taste also decreases. Taste decreases may lead to appetite loss, need for extra seasonings, or food complaints. Sometimes we hear families and staff just accept that food can't be expected to be good. We absolutely should expect food to be appetizing, and it is our job to make sure people don't settle. That's what our advocacy is for. Smell decreases can also affect appetite. Regarding vision changes, there's less ability for the lens to accommodate changes in distance, the need for more light, and glare can also become a problem. It may be difficult to distinguish color. There might be depth perception problems, which leads to fall risks, and larger print may be needed to read. Hearing loss is a particularly important sensory change because it can go unrecognized and lead older adults to feeling isolated. It's important to not assume that someone is hard of hearing, but to be as cognizant of this as a potential change associated with aging and look out for it. Our body systems change as we age as well. We'll talk about 3 different systems: circulatory, digestive, and urinary. Within the circulatory system, our hearts change as we grow older, and sometimes circulation becomes weaker. Changes to the circulatory system can lead a person to appearing confused or stumble and fall if they stand up too quickly. After the heart has had sufficient time to pump the blood throughout the body, the unsteadiness or confusion disappears. One of the systems least affected by aging is the digestive system. As in earlier years, diet and exercise are extremely important to maintain proper functioning. Teeth become more brittle. Saliva, necessary to swallow food, decreases. The thirst response decreases. The speed and effectiveness of digestion and elimination may decrease. Choking on food is a greater risk because of a decreased gag reflex and decreased saliva. There is a variety of adaptations that can be made for prevention and to address the problems when they occur. The urinary system experiences several changes. A general weakening of the bladder muscles means that the impulse to urinate cannot be delayed as long as in earlier years. When an older person says, "I have to go to the bathroom," that usually means now. With weakened muscles with the bladder may not empty completely, which increases susceptibility to urinary infections, a common ailment in nursing homes that can be prevented in many cases. The kidneys filter the blood more slowly, and as a result, medications remain in the bloodstream longer than they do in younger people. That change in functioning compounds the danger of over-medication. Doses of medicine need to be closely and continuously monitored. Interaction effects between prescribed medication and over-the-counter drugs, even aspirin, are more likely to occur. There's no doubt you'll interact with residents who are at the end of life. You may or may not feel comfortable with that. When ombudsmen are making advocacy visits and checking in with residents, we may not know that someone is at the end of life until we talk to them. Listening is very important. The dying person may not talk much and should not be pushed. Make your visits short and be an advocate for any preferences they talk about. The bottom line is that characteristics vary. Never assume. The long-term care residents that we work with are more different than alike. The changes in function can vary significantly, and as an ombudsman should never assume a loss. This includes personal changes in lifestyle and activity. How individuals deal with change varies too. Strategies for coping will vary from person to person. This is why individualized and person-centered care is so important. In a future fieldwork assignment, you'll get to know a long-term care resident by conducting a phone, virtual, or in-person interview. You'll ask them questions about their experiences while living in the long-term care setting. You'll follow up with your volunteer coordinator to share what you've learned. Moving on to Section 3, we'll talk about common health experiences. Individuals living in long-term care facilities need a variety of supports and services related to their diagnosis. Most people living in long-term care are not there because of the diagnosis, but because they need help managing the effects of their conditions. Many residents have more than one illness. According to resident data, some of the most common physical health diagnoses in nursing facilities include high blood pressure, high cholesterol, diabetes, heart disease, and arthritis. Although the common physical health conditions discussed in this section are based on data from nursing facilities, residents in assisted living facilities often have similar chronic health issues. We know that about 6 in 10 adults in the United States live with a chronic disease. 4 in 10 adults live with 2 or more chronic diseases. As ombudsmen, we are not clinicians, and we don't expect you to be experts in this area. We'll just provide an overview of a few conditions and talk about how you can advocate for residents. Listed here are some common chronic diseases that we're going to talk about today, including diabetes, heart disease, stroke, cancer, kidney disease, and lung disease. Diabetes is a chronic health condition that affects how the body turns food into energy. People with diabetes will need to routinely check their blood sugar, but how often this is needed depends on the type of diabetes the person has. It is also important to note that diabetes can lead to other serious health complications that a long-term care provider may need to help a resident manage, such as vision loss, kidney, or heart disease. There are two types of diabetes, type 1 and type 2. Type 1 diabetes occurs when the body does not make enough insulin. Type 1 diabetes is unpreventable and can develop at any age. Type 2 diabetes occurs when the body can't use insulin properly. Most cases of type 2 diabetes can be prevented through diet and exercise, but genetics can play a role in type 2 diabetes developing, which can also happen at any age. There isn't yet a cure for diabetes, but losing weight, eating healthy, and being active can really help. In nursing homes, staff are responsible for medication distribution and routine monitoring of residents with diabetes to keep their blood sugar levels within a normal range. Mismanagement of diabetes can be fatal. As an ombudsman, you may work with residents who have diabetes that might choose to manage it differently than you might, or than a healthcare provider might. For example, meal choices play a role in diabetes management. For some, giving up their favorite sweet treat or carbohydrates is not a big deal. For others, this could have significant negative impact on their quality of life. Your job as an advocate is to learn from residents what's important to them and work with them to reach their goals, regardless of how that matches up with the wishes of the staff. The term heart disease refers to several types of heart conditions. In the United States, the most common type of heart disease is coronary artery disease, which can lead to a heart attack. Coronary artery disease is caused by plaque buildup in the wall of arteries that supply blood to the heart. Plaque is made up of cholesterol deposits. Plaque buildup causes the inside of the arteries to narrow over time. A heart attack happens when part of the heart muscle doesn't get enough blood and is often the first sign of heart disease. So let's talk about the treatment for a resident with heart disease. Residents with heart disease may have a special diet, like a low-sodium, low-fat diet. Increasing physical activity, reaching a healthy weight, and quitting smoking are recommended for people with heart disease. Smoking could also be one of the situations you encounter. A resident with heart disease might think that it's not worth stopping, and they like to smoke. It is their right to smoke, and even if you or I don't like smoking, it's still their right. Residents with heart disease may also be on medication to treat high cholesterol, high blood pressure, or an irregular heartbeat. And some residents may require surgery to help restore blood flow to the heart. Physical activity can be helpful for someone recovering from a heart attack, heart failure, or other heart problem that needs surgery or medical care. Residents may participate in physical therapy to build heart strength. Some residents may enter long-term care to receive short-term rehabilitation after such a surgery. Typically, these residents are in short-term rehabilitation. Providers should help these residents in a smooth transition back to the community, including setting up physical therapy at home to continue working on strengthening. And be aware that often residents enter a home for short-term rehabilitation and end up staying for far longer than intended, sometimes because of complications and lack of good care to help them get better. Strokes can happen when blood flow to the brain is blocked, when arteries leak or arteries rupture. A doctor may give residents medications or recommend that they change their diet, exercise habits, or adopt other healthy lifestyle habits. Surgery may also be helpful in some cases. You might also hear someone call a stroke a CVA for cerebrovascular accident. Some residents may enter long-term care because they need short-term rehabilitation after having a stroke. Other stroke survivors may have been left with paralysis that impairs their independence. These residents may require care and help with activities of daily living, including eating, bathing, grooming, using the bathroom, and more. As an ombudsman, you should consider if they can reach their call light button easily. Can they reach their water easily? Are they able to move around and prevent pressure sores, or is that something the provider needs to watch for? Are they getting enough help to the bathroom? And are they getting out of bed as much as they would like? It may be difficult to understand or effectively communicate with the person who has had a stroke without being prepared. Don't ever assume a person cannot communicate with you or doesn't understand you, but check in with them and ask how they might like to communicate with you if you run into issues. Remember that if you're having trouble, the staff of the home might be having trouble too. There are lots of great assistive devices available to those that might like to use them. Assistive communication devices should be used to keep the resident involved as an active participant in their care plan. Cancer is a disease in which some of the body's cells grow uncontrollably and spread to other parts of the body. It can start almost anywhere. According to the CDC, the most common types of cancer by rates of new cases are breast cancer, prostate cancer, lung and bronchial cancer, and colon and rectal cancer. There are many types of cancer treatment that residents you are working with may be experiencing. The types of treatment that a resident receives will depend on the type of cancer they have and how advanced it is. Some people with cancer will only have one treatment, but most people have a combination of treatments, such as surgery with chemotherapy or radiation therapy. Cancer treatments can be exhausting and make residents feel ill. When scheduling a meeting with a resident who is going through one of these treatments, it's very important to ask when they might want to meet. Here's just a few tips for engaging with residents that have been diagnosed with cancer. First, you want to take your cues from the resident. Don't bring it up unless they want to talk about it. Second, choose words carefully, such as, "I'm sorry this happened to you. How can I help make your situation better for you?" Don't say things like, "I know how you feel. I know someone that had the same diagnosis. Don't worry, you'll be okay." Third, if they feel physically up to it, encourage socialization of some type. Kidney diseases are the 9th leading cause of death in the United States. About 37 million U.S. adults are estimated to have kidney disease, and most are undiagnosed. Many people who have it are not aware of it. The kidneys can become damaged and cannot filter blood as well as they should. Excess fluid and waste from blood remain in the body and may cause other health problems, such as heart disease and stroke. When the kidneys stop working, dialysis or kidney transplant is needed. Unfortunately, those who undergo dialysis treatment have an increased risk for getting an infection. Hemodialysis is a type of dialysis that often requires travel to another healthcare provider to receive, but sometimes they're done at nursing homes. If you want to schedule a visit with a resident who receives these treatments, it's important to ask when to schedule the visit, because the resident could be out a few days each week. People who have hemodialysis treatments are at a high risk for infection because the process requires frequent use of catheters or insertion of needles to access the bloodstream, and residents may have weaker immune systems. Residents who go through these lengthy treatments are often worn out afterward and can even be tired the next day, so scheduling a visit to accommodate this is important. Chronic lung disease is a catch-all term for hundreds of lung diseases that affect the airways, lung tissues, or circulation of blood in and out of the lungs. Today we'll discuss a few of the more common ones. Asthma is one of the most common chronic lung diseases. When triggered, the lungs become swollen and narrow, making it harder to breathe. Most people with asthma can manage it fine and enjoy full and healthy lives. Chronic obstructive pulmonary disease, also called COPD, is a chronic lung disease in which lungs become inflamed, making breathing more difficult. People with COPD typically have one or both of the following conditions. Emphysema. Emphysema damages the air sacs in the lungs. It also weakens them and eventually causes them to rupture. Chronic bronchitis. You may have experienced bronchitis when you had a cold or sinus infection. Chronic bronchitis is more serious as it reoccurs. It causes inflammation of the bronchial tubes in your lungs. Pneumonia is an infection that inflames the air sacs in one or both lungs. The air sacs may fill with fluid, causing cough with phlegm, fever, chills, and difficulty breathing. For older adults and people with compromised immune systems, it can be life-threatening. Because chronic lung disease represents so many different diseases, treatment plans can vary. A few treatments that are common include medications, like prescription inhalers, antibiotics, and cough suppressants, or supplemental oxygen. People with chronic lung disease are at a higher risk for developing a more serious case of COVID-19. Part of managing this disease is infection control. Something like a cold, flu, or COVID can be fatal to people living with chronic lung disease. It's important just to understand that regardless of a resident's diagnosis, they still have the right to make decisions about their care. This could mean that a resident with chronic lung disease may still want to smoke, regardless for the potential of negative consequences. It is also important to consider advocating for portable oxygen so consumers can be more mobile, taking oxygen with them to activities or on outings. It's important to understand the basics of these chronic diseases so that you can recognize when a condition is being obviously mismanaged, and you know when to expect a resident to be out, on medication, or have certain physical characteristics. But you are not required to be an expert and should not provide direct care or give medical advice. Your role is to help residents get access to excellent care. You can educate residents, advocate for better care, and inform Ombudsman Program staff of problems. Remember that above all, the residents' rights and preferences should be prioritized, regardless of what chronic disease they might have. The next few slides, we're going to discuss how a resident's chronic disease can affect your advocacy by running through a few scenarios. There are 3 scenarios total. Scenario 1. It is a sunny afternoon and you are at your assigned nursing home for a weekly advocacy visit. You decide to start your visit by popping in on Betty, a long-term care resident that you know pretty well. When you approach Betty's room, you hear her speaking in an elevated tone to someone. "You can't take it because it was a gift for my granddaughter and I want it." You can tell that Betty is upset. As you approach the room, an aide walks out holding a Kit Kat bar and shaking her head. You ask the aide, "Is everything okay?" And the aide sighs and lets you know that she caught Betty, who has type 2 diabetes, trying to eat a candy bar. How do you handle the situation? So in handling this situation, we would first talk with Betty about what the staff member said. If Betty is aware of her diabetes, ask how she normally deals with it in order to know whether she's making an informed decision. To resolve the problem, we want to focus on Betty's right to make decisions about her care. If Betty would like to have a candy bar, even as someone with diabetes, she has the right to make that decision for herself. People with diabetes living in the community can make these decisions for themselves each and every day. Betty is an adult and should be treated as such. The staff do not allow her to have a candy bar. She made an informed decision to eat a candy bar. Moving on to scenario 2. After assisting Betty, you decide to move along to a new resident in the room adjacent to Betty's. You politely knock and ask to come in, introduce yourself, and find out that the resident's name is Janet Peterson. She just moved in 4 days ago. Janet seems agitated. She tells you that she missed an important appointment yesterday because the staff did not arrange her transportation. She tells you that she really isn't feeling well. How would we handle this situation? First, we want to ask what questions to see what appointment Janet might have missed. We learned that Janet has chronic kidney disease and she missed a dialysis appointment. This is a situation that is urgent and may need to involve the staff ombudsman. Janet's health is at risk without her dialysis, and it is the provider's responsibility to get Janet a new appointment as soon as possible and arrange transportation to the appointment. As part of resolution, the ombudsman should ask the provider how they will prevent such a problem in the future. The volunteer then should follow up with Janet during a couple of subsequent visits to make sure the correction is still working and that she hasn't missed more appointments. And finally, moving on to scenario 3. After helping Janet, we move along to the next room. Robert is watching TV in his room, and when you enter, he switches it off and asks, "Are you the ombudsman?" You tell him you are and ask how you can help him. "The staff around here won't let me smoke. I'm an adult and they're trying to take my rights away," he exclaims, obviously very upset. How would we handle this situation? As we speak to Robert, we'll discover that he is a cancer survivor, specifically lung cancer. It is believed that his smoking caused his cancer, so staff have taken his cigarettes from him to prevent the recurrence of his cancer, per his daughter's instructions. His daughter has financial power of attorney. The goal of this is to know when to involve the staff ombudsman, know when to speak with staff, and realize that the resident has the right to smoke, even though he is a cancer survivor. We want to find out what is in Robert's care plan, what he understands about why the staff keep his cigarettes, and whether he has spoken with his daughter about how he feels about the smoking policy. Also, we need to realize that Robert has a financial power of attorney. This does not give the daughter authority to make decisions about Robert's health care. Even if she had a health care power of attorney, as long as Robert has capacity to make decisions, it is his right to do so. There are many different types of disabilities that we'll touch on now. Mobility disabilities means a person has difficulty ambulating, like walking or climbing stairs. People with mobility disabilities may use assistive technology to help them. People who have limited mobility may also rely on caregivers to turn them while they're in bed and assist them in getting out of bed. If turning does not occur on the right schedule, skin can actually become damaged and break down, leading to pressure sores or ulcers. Cognitive disabilities means a person has difficulty concentrating, remembering, or making decisions. With intellectual or developmental disabilities, this means a person has a below average cognitive ability with 3 different characteristics. Their IQ is between 70 or 75 or below. They have significant limitations in adaptive behaviors, like the ability to adapt and carry on everyday life activities, such as self-care, socializing, or communicating, and is onset before age 21. Hearing disability can mean being deaf or being hard of hearing. They may prefer to communicate with you through a variety of means, including by writing or through a sign language interpreter. Vision impairment can also mean total blindness or being legally blind. Disabilities can affect someone's ability to live independently. People with disabilities may have difficulty performing activities of daily living without assistance. Sometimes this leads a person to move into a long-term care provider for such assistance. Providers must have a person-centered care plan in place for every resident that includes information about what their unique needs are and how they prefer to receive care and communicate. Care should be approached and not from what the person cannot do, but from the perspective of what they can do. Individuals with disabilities are more likely to have poorer overall health and have less access to adequate health care. They are also often at a greater risk for health problems that can be prevented. In some instances, as a result of having a specific type of disability, such as a spinal cord injury or multiple sclerosis, other health conditions can occur. Some of these other health conditions are also called secondary conditions and might include bowel or bladder problems, fatigue, injury, mental health and depression, obesity, pain, or pressure sores and ulcers. Residents who have one or more disabling conditions may have difficulty accessing services, remaining engaged in services, knowing what supports they need, or consistently using supports. Reasons for these barriers vary, but some barriers are created by cognitive and/or behavioral weaknesses, lack of caregiver support, or lack of knowledge. It is important for the Ombudsman to be aware of services and supports that can aid residents with disabilities. Now we'll learn a bit about traumatic brain injuries. A traumatic brain injury, also known as a TBI, is an insult to the brain caused by an external force that results in an altered state of consciousness and one or more impairments of brain functioning. Effects can be temporary or permanent. As you can see from the chart here, there were over 111,000 emergency department visits due to TBIs in 2014, and we expect that many more TBI incidents occurred that did not result in a person receiving care. With TBI, a person's life abruptly changes in a moment. Since our brain defines who we are, the consequences of a brain injury can affect all aspects of our lives, including our personality. A brain injury can be classified as mild if loss of consciousness and/or confusion and disorientation is shorter than 30 minutes. Severe brain injury is associated with loss of consciousness for more than 30 minutes and memory loss after the injury or penetrating skull injury longer than 24 hours. Survivors may have limited function of arms or legs, abnormal speech or language, loss of thinking ability, or emotional problems. They might even be in a coma. Recovery is variable, and the effects of TBI can be profound. Individuals with severe injuries can be left in long-term unresponsive states. For many people with severe TBIs, long-term rehabilitation is often necessary to maximize function and independence. Even with a mild TBI, the consequences to a person's life can be dramatic. People who experience TBIs may utilize long-term care services during their rehabilitation and beyond, depending on the severity of their injury and the level of support they have at home. They often have unique needs and require specialized assistance that providers should be in tune with. One of the consequences of brain injury is that the person often does not realize that a brain injury has occurred. A mental illness is a condition that impacts a person's thinking, feeling, or mood, and may affect his or her ability to relate to others and function on a daily basis. Severe and persistent mental illness, also known as SPMI or SMI, is a term you may hear during your advocacy. SMI is often defined by its length of duration and the disability it produces. These illnesses include disorders that produce psychotic symptoms, such as schizophrenia and schizoaffective disorder. Other severe forms of other disorders, such as major depression and bipolar disorder. Another type of SMI is sometimes called a thought disorder. This can include illness that produce distortions of perception, delusions, hallucinations, and unusual behaviors. Severe mental illnesses are treatable, and with proper treatment and management of the illness, people with these disorders can experience recovery. Stigma surrounding mental illness can be detrimental to long-term care residents. Residents may be resistant to seeking help or treatment for fear of being labeled. Residents may also think that they will be treated differently because of their mental illness or feel ashamed that they are struggling in this way. You will encounter residents with mental illness, but there are public policies and systems in place to make sure a person with mental illness receives treatment in the setting that is best for their needs. Sometimes nursing homes make rules or behavioral contracts with residents that are inappropriate. If you have concerns about what you see, like residents walking aimlessly, staff not interacting with them, or giving them rules like not being allowed outside if they don't take their medication, you should promptly report that to the staff ombudsman. According to the Ohio Department of Mental Illness and Addiction Services, no person with mental illness who does not also have physical illness should go to a nursing home because of the mental illness. No person with mental illness and physical illness should be denied nursing home care because of that mental illness. Admission to a nursing home is not compatible with the concept of recovery and represents a failure of the treatment system. It is inconsistent with values of freedom, choice, and dignity. The most diagnosed mental illnesses are anxiety and depression, so it is likely that you will run into residents who have one or both of these diagnoses. Depression and anxiety can be acute or chronic. Acute mental illness is usually a short-term mental health disorder that is caused by an event. For example, a loved one passing away may cause depression symptoms, but these symptoms will not be long-term. Depression varies greatly in severity. A person with depression may experience feelings of hopelessness, low self-esteem, lack of motivation, loss of interest in normal daily activities, as well as activities that used to bring them joy. Depression may be severe enough that a person may not feel able to get out of bed in the morning and may spend the whole day sleeping. In addition to extreme feelings of sadness, those with debilitating depression may also experience restlessness, irritability, change in appetite, difficulty concentrating, fatigue, and guilt. People with debilitating depression may also think about death frequently and experience suicidal thoughts. The national average for long-term nursing home residents with depression symptoms is about 7%, but in Ohio, it's about 20%. Experiencing occasional anxiety is a normal part of life. However, people with anxiety disorders frequently have intense, excessive, and persistent worry and fear about everyday situations. Often, anxiety disorders involve repeated episodes of sudden feelings of intense anxiety and fear or terror that reach a panic within minutes, also called panic attacks. These feelings of anxiety and panic interfere with daily activities, are difficult to control, are out of proportion to the actual danger, and can last a long time. Post-traumatic stress disorder, also called PTSD, is a mental health condition that's triggered by a terrifying event, either experiencing it or witnessing it. Symptoms may include flashbacks, nightmares, and severe anxiety, as well as uncontrollable thoughts about the event. Most people who go through traumatic events may have temporary difficulty adjusting and coping, but with time and good self-care, they usually get better. Obsessive-compulsive disorder, also called OCD, features a pattern of unwanted thoughts and fears, or obsessions, that lead someone to do repetitive behaviors, or compulsions. These obsessions and compulsions interfere with daily activities and cause significant distress. Someone may try to ignore or stop his or her obsessions, but that only increases distress and anxiety. Ultimately, people with OCD will feel driven to perform compulsive acts to try to ease their stress. Schizophrenia is a serious mental disorder in which people interpret reality abnormally. Schizophrenia may result in some combination of hallucinations, delusions, and extremely disordered thinking and behavior that impairs daily functioning and can be disabling. People with schizophrenia require lifelong treatment. Recovery from mental disorders and/or substance abuse disorders is a process of change through which individuals will improve their health and wellness, live a self-directed life, and strive to achieve their full potential. There are 4 major dimensions that support a life in recovery. Those include health, home, purpose, and community. With health, people have the right to make informed, healthy choices that support physical and emotional well-being. They have a right to have a stable and safe place to live. They should engage in meaningful daily activities, work for independence, creativity, and resources to participate in society, and also build relationships and social networks that provide that support. Long-term care providers should aid in this recovery process by assuring that residents with mental illness are getting the care and support they need. This involves ensuring that residents using medication as part of their mental health recovery are taking them on schedule and in the right doses. It means ensuring regular access to a prescribing doctor with the appropriate specialization who can provide wellness checks and effective mental health screenings. It means ensuring access to mental health professionals and resources to keep the resident connected to those resources, whether that be payment options, assistance programs, or benefits. Lastly, it means the provider should create an environment that is safe, engaging, social, and ultimately supports the mental and physical well-being. With these following three scenarios, we're going to discuss how a resident's physical and/or mental illness can affect advocacy. With this first scenario, continuing our advocacy visit, we enter the room of a resident who has recently moved in. His name is printed on a piece of paper and attached to the door frame next to his room number, John Daly. You enter the room and see a man laying in bed, and you notice right away that the right half of his face is drooping. You introduce yourself and find that John is paralyzed on his right side due to a stroke he had 2 years prior. What would you consider when interacting with someone who is paralyzed from a stroke? What questions do you ask about care? What do you hope to find in his room? So we should ultimately want to focus on the quality of care that John is receiving, whether that's incontinence care, whether he's on a special diet, in physical therapy, does he have assistive devices? Is his call light within reach? Is his meal tray within reach? If the right side of his face is drooping, that indicates that the stroke occurred on the left side of his brain, which means that he is likely to have speech problems and understanding language. He also may have visual problems. Moving on to the next scenario, we move on to the next room and notice that an aide is standing at the foot of the bed of this resident, writing on a portable whiteboard with a dry erase marker. She hands the board to the resident after she's finished writing. After a few seconds, the resident erases what she wrote and begins to write a message of his own. You walk into the room, introduce yourself to the aide and the resident. The resident motions to his ear and says, "I'm hard of hearing." How should we handle this situation? So ultimately, we should focus on whether the whiteboard meets the resident's needs. There are assistive devices out there beyond whiteboards that can be provided to those who are hard of hearing. Does he need an interpreter? Is he missing hearing aids? We can also discuss what the facility should do to accommodate his physical disability and improve his care. Moving on to section 4, we'll talk about dementia, including Alzheimer's disease. In the course of your advocacy, you'll work with folks who have dementia in long-term care fairly frequently. $5.3 million Americans are affected by dementia, not to mention the impact on family and friends. It is estimated that just under 14 million people will be affected by 2050. It is the fifth leading cause of death for people over the age of 65. Up to $215 billion is spent in annual care costs and dementia care. This accounts for roughly 75 to 84% of long-term care expenses. Family and friends are often caregivers, and it's crucial that they understand how to best meet their loved one's needs based on where they are in the disease process. Having this knowledge can go a long way, especially when caregivers need to pivot their approach to care, communication, or emotional support moment to moment. We'll go over the stages of dementia here in a little bit, but first we're going to talk about ways that caregivers can support their loved ones. For example, if a loved one is caring for someone who is in the early stage of dementia, it's not likely that the person will need assistance taking a shower. But the caregiver can help provide gentle reminders or cue them to shower without making their loved one feel embarrassed. They may also put a sign on the door identifying the bathrooms in the house. For someone who's in the middle stages of dementia, their caregiver may need to help them prepare meals. The caregiver doesn't need to do every step, although it seems like that would be the easiest. It's best to have the person help where they still can and to support them where needed. The more the caregiver does, the less the person with dementia is able to do for themselves. Think of it like, if you don't use it, you'll lose it. For someone who loved cooking, for example, being able to still fill a pot of water and add pasta can give them a sense of independence and may keep them more engaged in other activities. Changes in the way the caregiver communicates with their loved one may need to happen. If the individual with dementia can no longer safely drive, but they want to take the car out, it's important for the caregiver to communicate calmly. The caregiver should not yell at their loved one or tell them, "Remember, you don't drive anymore." Grounding them into our reality isn't helpful. It may upset the person because in their mind they can drive and they don't have the memory of not getting their license renewed. Instead, the caregiver should acknowledge their desire to want to leave the house and redirect their attention, perhaps saying, "I'm feeling cooped up in the house too. Will you come on a walk with me?" Or, "I know you want to take the car out, but the battery's dead and Sam won't be over to fix it until tomorrow." We call this therapeutic fibbing. Telling the person something that isn't true to help them get through a difficult moment can be helpful. The goal is to validate and shift focus. The better you know the individual with dementia, the easier it is to respond in ways that make sense to them. And what works today might not work tomorrow. This is why having a lot of options in our tool belt is important. So, who is at risk for having dementia? The number one risk factor is age. In fact, 1 in 9 people over the age of 65 and 1 in 3 people over the age of 86 have dementia. There's evidence to suggest that dementia could be inherited. This is especially apparent for families who have early onset dementia affecting family members before the age of 65. Interestingly, African Americans have a 4-time greater chance of developing dementia, and Hispanic Americans have a 2-time greater risk of developing it. The racial discrepancies are chalked up to heart disease and cholesterol. Environment is an indeterminate risk factor. Everything from aluminum to nicotine to latex to pollution has been blamed at some point for causing dementia. Some claim that leading a healthier lifestyle, being active, and eating healthy can reduce your risk of developing dementia. This is not normal aging. Normal aging may include slower recall, difficulty concentrating, and new info that takes a little bit longer to process. So what is dementia? Dementia is not a specific disease, but rather a general term for the impaired ability to remember, think, or make decisions that interferes with doing everyday activities. These affected abilities include memory, language skills, visual perception, problem solving, self-management, and the ability to focus and pay attention. Alzheimer's disease is the most common type of dementia. Though dementia mostly affects older adults, it's not a part of normal aging. It's important to remember that although some cognitive abilities change, people living with dementia can still lead a fulfilling life by being supported by their caregivers through adjustments to communication, which we'll talk more about later in training, and engaging persons with dementia in activities like music, dance, and art. Dementia ranges in severity from the mildest stage, when it is just beginning to affect a person's functioning, to the most severe stage, when the person must depend completely on others for basic activities of living. There are also different types of dementia, so what is affected is not always memory. It usually is, but it depends on the type or area of the brain affected. There are some treatments to slow or improve the symptoms of dementia. Some drugs on the market today work by boosting levels of the chemical messenger in our brains responsible for memory and judgment. Antipsychotics are still prescribed to treat symptoms of dementia-related psychosis in people with dementias, including Alzheimer's disease. They should not be used, however, unless the person exhibiting extreme behaviors has failed to respond to non-drug management strategies, including occupational therapy and environmental modification. Many antipsychotics come with a black box warning for older adults with dementia, indicating that risk of mortality is higher in these residents. It's important to know that there are some conditions like delirium and mental illnesses that can impact a person in ways that mimic dementia. If those conditions aren't treated, a provider might give inappropriate care and treatment that prevents them from getting better, and in some cases, moving back to the community. Delirium associated with infection, fever, or congestive heart failure can seem like dementia. UTIs are commonly mistaken for dementia, as they are difficult to detect and if left untreated, can cause confusion that mimics dementia. Also, reactions to anesthesia or other environmental factors can cause delirium that mimics dementia. These conditions or occurrences can cause certain symptoms that mimic the symptoms of dementia. These might include drug reactions, emotional disturbances, metabolic and endocrine disorders, nutritional deficits, and dehydration. Mental illness can also mimic dementia. Acute depression or an episode of extreme grief can temporarily affect memory, especially short-term memory. Chronic depression or conditions like major depressive disorder and persistent depressive disorder can also mimic signs of dementia like memory loss, loss of sleep, personality changes, and mood swings. If a person with mental illness is taking medication, it can also cause some of these things. Many of these conditions may be seen in residents. Post-surgery patients will have gone through a multitude of events that could lead to dementia-like symptoms, like a hospital stay, sleep deprivation, infection, or pain. 60 to 80% of all cases of dementia can be attributed to typical or early onset Alzheimer's disease. Early onset is rare, inherited, and progresses quickly. The symptoms of these two types of dementia include difficulty remembering recent conversations, names or events, and this is often an early clinical symptom. Apathy and depression are also often early symptoms. Later symptoms include impaired communication, poor judgment, disorientation, confusion, behavior changes, difficulty speaking, swallowing, or walking. Brain changes associated with Alzheimer's disease are deposits of protein fragment beta amyloid, or plaques, and twisted strands of protein tau, or tangles, as well as evidence of nerve cell damage in the brain. Vascular dementia makes up about 10% of cases. Vascular dementia onset may be more sudden and is often a response to an acute brain event, like a mini stroke. Initial symptoms include impaired judgment or ability to make decisions, plan, or organize, as opposed to the memory loss often associated with the initial symptoms of Alzheimer's. Vascular dementia occurs because of brain injuries such as microscopic bleeding and blood vessel blockage. The location, number, and size of the brain injury determines how the individual's thinking and physical functioning are affected. Lewy body dementia is characterized by abnormal protein deposits that disrupt the brain's normal functioning. Lewy bodies are abnormal aggregations or clumps of the protein alpha-synuclein. When they develop in a part of the brain called the cortex, dementia can result. This also aggregates in the brains of people with Parkinson's disease, but the aggregates may appear in a pattern that is different from dementia with Lewy bodies. Lewy body dementia can exist alone or in conjunction with Alzheimer's disease and Parkinson's disease. People with dementia with Lewy bodies often have memory loss and thinking problems common in Alzheimer's, but are more likely to have sleep disturbances, such as acting out dreams while asleep, well-formed visual hallucinations, muscle rigidity, tremors, stiffness, difficulty walking, or other Parkinson movement features. They can also experience behavioral and mood symptoms, including depression, apathy, anxiety, agitations, delusions, or paranoia. And finally, they can experience changes in autonomic bodily functions, such as blood pressure control, temperature regulation, and bladder and bowel function. Other types of dementia that are less common include frontotemporal dementia. This develops younger, and survival is shorter than Alzheimer's disease. This affects the impulse center of the brain, so typical symptoms are behavioral. Creutzfeldt-Jakob. This disease is very rare, marked by rapid mental deterioration, usually within a few months. It can include personality changes, memory loss, impaired thinking, blurred vision or blindness, insomnia, impaired coordination, difficulty speaking, sudden jerky movements, and most people eventually do fall into a coma. Huntington's disease is a progressive genetic brain disorder. There are involuntary movements, and there is a severe decline in thinking and reasoning, irritability, and depression. This disease is actually terminal after just a few years. Parkinson's is mostly associated with movement disorders, but it also results in progressive dementia like Alzheimer's disease and dementia with Lewy bodies. Substance use disorders can cause alcohol or drug-induced dementia. This is when the use of drugs or alcohol results in neurological damage and causes impaired executive decision-making. 50% of people with dementia are unaware of it in themselves. There are 3 stages of dementia: early or mild, middle or moderate, and late stage, but it's not precise. In the early stage of dementia, people are often cognitively intact and are able to adjust if they can stick to old and familiar routines, telling the same stories, and asking repetitive questions. Most people with early stage dementia think they're fine and appear fine, but get distracted easily, especially by the past, and they can get emotional quickly too. Inclusion of the resident in all decisions should be continued as long as possible to avoid isolation. As dementia progresses, people may lose fine motor skills, have diminished visual and auditory awareness. Sensory tolerance is also changing. People in this middle stage may have increased fidgeting, touching, and rummaging. They may also react physically and use routine phrases. Caregivers also need to help manage transportation, money, medications, monitoring, and security. As Ombudsman, we need to consider that fall prevention is important for these residents, as well as a schedule for hydration and using the bathroom. In later stages of dementia, people may use few words, even have a lack of coordination, trouble swallowing, and they may not always be aware of the world around them. They might be easily lost and spend a large amount of their time asleep. As Ombudsman, we should consider the following. Are they getting enough food and fluids? There's also a risk for dehydration when the person with dementia can't remember to drink. In this stage, there's also an increased need to support use of the bathroom, and if the individual becomes incontinent, there's a greater risk of skin problems and wounds, and UTIs. You will more likely encounter surrogate decision makers when working with someone with dementia, and it's our job as advocates to focus on what the resident communicates with us and ensuring that that surrogate decision makers are considerate of the resident's values and history. It's so important for caregivers to understand the history of the person with dementia. Understanding the resident's family life, professional role, hobbies or interests, and self-identity can aid in understanding a person's actions and expressions. Actions and communication. Caregivers need to understand the person's history so that the care can be focused. Often these clues come from family members. When communicating with a person who has dementia, it's important to not argue with them about what is real and what is not. Reality orienting can be confusing and distressing and come across as argumentative. Instead, validate their feelings. Look for messages in their actions. For example, shoes might mean mobility. A soft blanket might mean comfort or feelings of home. A purse might mean independence, and the ability to choose means having control. People with dementia can also experience mental illness, such as anxiety or depression, and it manifests in the same symptoms as someone without dementia. Depending on the setting, long-term care staff receive varying levels of training. In nursing homes, nurse aides are required to receive 12 hours of formal in-service education a year, which may be web-based. If the provider holds itself out as offering specialty care, whether that's dementia care, behavioral care, mental health, or hospice care, they must provide sufficient additional hours each year to ensure competency in the specialized care needs. In residential care facilities, if a provider admits or retains residents with late-stage cognitive impairment with significant ongoing daily living assistance needs, or cognitive impairments with increased emotional needs, or expressions that cause problems for the resident or other residents, this facility should have 2 hours of initial training in the care of such residents within 14 days of the first day of work, and 4 hours of continuing education in the care of such residents annually. The 4 hours of continuing education may count toward the continuing education requirement. In 2021, there was a state dementia task force working on a variety of issues, including effective preparation of paid caregivers. In adult group homes, or RF2s, 6 hours of continuing education relevant to resident care during each licensure period is required. Nothing specific to dementia care. They must have training in mental illness and substance abuse disorder if the provider accepts residents with them. The next few slides, we're going to go over a couple more scenarios to discuss how a resident with dementia can benefit from your advocacy. Scenario 1. Continuing on your advocacy visit, you enter the dining room and notice a woman in a wheelchair sobbing uncontrollably. She looks visibly very frightened, and you hear her say, "I have to go home. She needs me." You see an STNA and a dietary aide nearby, but no one is moving to the resident to ask her what is wrong or to help her. You approach the aide and ask, "Is everything okay?" As you motion to the resident who is crying. "Oh, she has dementia," the aide replies. How would you handle the situation? Ultimately, we should focus on the idea that people with dementia-related anxiety should not be ignored. The resident's expressions are their communication. If the aide speaks to the resident, she'll discover that the resident believes that her child is home alone after school. The aide should validate, not try to correct her. What could she do to help the resident? Perhaps she could ask the resident about her children and talk about what it was like to raise children. Could she distract the resident with a creative activity like music or art? The aide should focus on the resident needing specialized care and not ignoring her. With scenario 2, you enter the wing nearest to the dining room, enter a resident's room, and discover a young woman sitting with the resident holding a pill. She is speaking with someone on a cell phone. Her voice conveys concern as she says, "I have no idea what this medication is. No one asked me before prescribing it to her." The resident is seated at a table across from the young woman, fidgeting with the blanket in her lap that has knobs, springs, strings, and other doodads attached to it. Upon seeing you, the young woman hangs up the phone. "Can I help you?" she asks. You explain your role in the Ombudsman program. She seems relieved and excited when she realizes that you can most likely help her. "Oh, thank goodness you're here. I have no idea what this medication is, but the home's physician prescribed it to her." She holds out a pill to you and says that she looked it up and it's called clonazepam. How do you handle this situation? So this scenario introduces the idea of chemical restraints. It also introduces the issue of medication control. Through conversation and asking open-ended questions, we discover that the young woman is the daughter of the resident seated at the table, and the resident has middle-stage dementia. We want to focus on what we can do to help the daughter and the resident. We want to think about consent, speaking with resident representatives, and providing medical information. We can ask to speak to a nurse and ask why that was prescribed and if it's appropriate for people with dementia. We can also help the resident figure out what questions to ask the doctor who prescribed it. The idea is to not give medical advice, but provide her information, empower the daughter to take action on behalf of her mother, and alert the regional program staff of a possible chemical restraint case. For Section 5, we're going to talk about dispelling myths and stereotypes. Stereotyping and myths can affect the medical treatment older individuals receive and the way caregivers treat them. Clinical expertise is beginning to challenge many commonly held perceptions about aging and interventions. You might hear things like, "We've always done it this way." "We don't have the staff to help Mr. Jones to the bathroom as frequently as he would need, so we're putting in a catheter." Staff might think, "Why should I help him brush his teeth? Why bother making sure she's looking her best if she's not going to go anywhere anyway?" As Ombudsman, you need to know which conditions indicate a need for more assessment and/or consideration of different treatment interventions, instead of assuming that the conditions are simply manifestations of the aging process. Remember, a nursing home must provide services and activities to attain and maintain the highest practical physical, mental, and psychosocial well-being of each resident in accordance with a written plan of care. Picking up from the last slide, in short, this means that people should not get worse because of what the nursing home does to them. In fact, they should reach the highest level of functioning and well-being that they're capable of achieving. If a resident was able to walk, transfer, bathe him or herself, move him or her arms, and maintain his or her skin when they moved in, they should still be able to do it after 6 months or a year, or for the rest of the stay in the home, unless circumstances of their clinical condition demonstrate that decline was unavoidable. There are only 3 reasons that decline is unavoidable. A new disease or condition is experienced by a resident, like heart disease added to Parkinson's. A resident's disease progresses, like the Parkinson's medicine no longer works and the individual becomes immobile, or a resident chooses not to receive treatment. This slide and the next just to talk about several myths that you might encounter during your advocacy. Feel free to take a second and pause to read these myths about care and the reality about care. This slide talks about the myth about disabilities and the reality of disabilities. There are several untrue and insensitive myths and stereotypes about people with physical and mental disabilities and illnesses. Here are just a few of the common myths. Again, feel free to take a second and pause to read. This slide discusses myths about mental illness and reality of mental illness. That concludes the end of Module 2. There is a self-study assignment attached to this module. The goal is to identify an example of ageism in media and complete the accompanying worksheet.